I would say we can start. So hello, everyone, and welcome to today's webinar session in which we will speak about Toric IOL planning with the Lensstar and the Eyestar. I would like to introduce today's presenter, Thomas Beutler, who is working with Haag-Streit for more than 15 years as a product manager. Thomas is currently responsible for the Eyestar, and we are both working closely together when it comes to biometry and IOL topics at Haag-Streit. With this said, I have the pleasure to introduce myself. My name is Michael Rieger, and I am working with Haag-Streit as a product manager for close to 2 years now. As mentioned, together with Thomas, I'm overlooking biometry and IOL related topics at Haag-Streit. I will start with basic information about IOLs and Toric IOLs. I will show you how iSuite helps you performing Toric IOL calculations and other features it provides. I will address which information the Lensstar provides for Toric IOL calculation, and Thomas will speak about dedicated features of the Eyestar. IOL means intraocular lens, and thus it is a lens that is implanted in the eye as a replacement of the crystalline lens that became opaque for reasons of age, trauma, or others. Symptoms are basically the reduction of vision. In these cases, we speak about pseudophakic IOLs. Another type of IOL is the phakic IOL, which is a lens that is placed additionally to the crystalline lens for treatment of myopia. In the following presentation, we will solely look at pseudophakic lenses or IOLs that are used to focus the light on the retina once the crystalline lens is removed. Before you get your crystalline lens replaced, some questions have to be discussed prior to the surgery. For example, does the patient prefer sharp distance vision and would like to correct near vision by using glasses? Would the patient be interested in monovision that could be enabled by using the right pair of IOLs, for example? There are different possibilities, and each one comes with its advantages and disadvantages. Besides these considerations, also the type of IOL affects the patient's vision. We have here a table of different IOL types. So we have the monofocal IOL are basically sharpening near vision or distance vision. I only marked here distance vision because this is the most preferred choice. As mentioned above, patients can choose where to correct, of course, depending on their habits. We have multifocal IOLs. As the name suggests, they provide correction for both for near and distance vision, because it is possible to focus either on near or distant objects. Some adaptation time is required to get used to this type of lens. We have the Toric IOLs, which is part of our topic of today. The Toric IOLs are a type of monofocal IOLs that allow to decrease the postoperative astigmatism. The correction of the astigmatism is in general recommended if the patient has an astigmatism of 1 diopter or more. Toric IOLs are available depending on the manufacturer from 0.75 diopter or 75 diopters to 4.75 or even further. Preoperative evaluation is important in order to manage the patient's expectations. So, for example, irregular astigmatism or poor pupillary dilation might impact the patient's vision negatively after the surgery. Accommodating IOLs are monofocal IOLs as well, so they provide sharp vision at a single focal point. Also here, typical distance vision is preferred, as I mentioned in the beginning for the monofocal IOLs. However, these IOLs come with flexible haptics that allow the IOL to accommodate, meaning moving the IOL slightly along the visual axis, which increases the power of the focus in near vision and thus provide better near vision than monofocal lenses or IOLs. Basically, these lenses somehow are made to mimic the crystalline or the behavior of the crystalline lens. These IOLs are preferred because they reduce the need for reading glasses. Once more, I want just to mention The later three, so the multifocal toric and accommodating IOLs, they are so-called premium IOLs. Once more, I also want to mention that managing the patient's expectation is really important. Pre-operative evaluation of biometry data, visualization of regularity of the corneal astigmatism, for example, or visual examples of how the selected IOL will impact the patient's vision can really be an asset when it comes to the planning of a toric IOL implantation. Now, I will present you how the workflow of iSuite looks like that provides the user the features he needs for calculating toric IOLs. As a first point, we have biometry measurements itself. As we have seen previous webinars on best practice when it comes to measurements, to biometry measurements with our optical biometers, I won't go into details here. Of course, you can ask questions if there are any. When it comes to the workflow, I just want to mention that our iSuite software flawlessly integrates in the existing IT environment. As such, one can trigger biometry measurements not only manually, also it is possible to trigger them via DICOM or similar. The biometry data validation was already covered by the webinar held by Carrie Menard previously. As a small reminder, we show all the measurement results on the overview page. So this is the one you can see here on the right. If any of the measured values exceed a certain standard deviation, a warning symbol might be shown to attract the attention of the user in order to ensure highest quality of the taken measurements. Here's an example of several A-scan measurements. In case one would not show good measurement, it could be removed to decrease standard deviation. So you can see here these 4 different measurements in this example. The same holds for keratometry readings. As you can see here, these 2 rings, this is the example for the keratometry readings, which of interest for the toric IOLs, of course. As mentioned already, we present warning messages to the user once the taken measurements don't fulfill the best practice guidelines provided by Dr. Warren Hill. These were also discussed in a previous webinar. I just want to bring them up here once more because I have several questions about these guidelines, and I just added here on the bottom right the link to download this PDF file. Which IOL and formula, or once the data have been measured, the user has the option to decide by himself which IOL to take and which IOL formula to work with. Which IOL and formula to use depends on the individual preferences of the eye care specialist. With iSuite, we provide a complete collection of iSuite formulae and also a template where each template holds multiple combination of IOLs and formulas. So this is the illustration you can see here on the right. Each combination or new combination can be added, removed, or rearranged. This is rather important because the printouts processed will find its place in the OR during cataract surgery potentially. In this case, you can see different combinations of IOLs and formula. Out of these 7 combinations that are shown here, there are 2 IOL calculations for toric IOLs. The information provided for the toric IOLs is the power of the IOL, the calculated post-operative refractive error, which is shown, the post-operative or residual astigmatism is shown as well. Here on the right side, you can also see in the illustration the orientation of the IOL that has to be implanted. Of course, the toric IOL, for the toric IOL, this is important as their astigmatism correction require it to be well aligned. For toric IOLs, we provide the surgery planner, which shows an image of the patient's eye, which was taken during the measurement process. As an overlay, there is the incision location and size. Both can be adapted to the user's needs in order to customize to the needs of the eye care specialist. The overlay of the IOL provides information on how to rotate the IOL in the patient's eye. Depending on the incision parameters, this orientation can slightly change to correct for the lowest residual corneal astigmatism. On the right side, again, we provide information about the chosen IOL, the cylindrical power, and the residual astigmatism. Eyestar provides several tools like geometric shapes to highlight important information like an arrow or text input. If there's some important information which should then show up in the IOL printout, which I will show you in a minute, this information can be added here. If required, to take an image of the eye can be optimized with color correction or histogram equalization, but there are more options available, of course. Besides the functionality I just mentioned, the incision location optimizer is giving the user a hand when it comes to choosing the optimal incision location, meaning the incision location which results in the least residual corneal astigmatism, which is plotted on the right side as a function of the angle of the incision location, which you can see here in red, where you see the residual astigmatism. Blue is the actual position of the incision currently, and black, in black, the horizontal black lines show the different proposed IOLs. The next point is the IOL printout. As you can see here on the right, it provides this printout provides the information based on the chosen IOL template I've shown you before. Biometry data of both eyes are shown, as well as the predefined IOL formula combinations. The user has also the possibility to select preferred combinations, as you can see highlighted here in green, for example. You have additional biometry data on top of the page, different combination for both eyes. And besides this information, the IOL printout shows the information of the surgery planner, as explained earlier. We hear very often that this information is highly valuable during cataract surgery. Furthermore, I would like to mention that the shown information can also be exported automatically and be exported digitally to be imported by cataract surgical guidance systems, for example. So now that we made an excursion in how to calculate which capabilities Eyestar provides to calculate toric IOLs, let's come back to measurements the Lensstar can provide. As explained already, we provide biometry data, like seen here on the overview page, like the axial length, the central corneal thickness, keratometry readings, and others. The dual zone reflective keratometry readings consist of 2 rings with 16 markers each and provide information about the corneal curvature, which holds information about astigmatism and the axis. This dense point pattern consists of 32 points, and they allow for high precision readings. Also here, once more, you see, like I have explained before, here, for example, there is one of these measurements is crossed out because it is marked as being not a good measure, and this is the way how you can reduce the standard deviation for your overall measurement. With the optical decone toric platform, so here, what is the decone? It's an additional piece of hardware which is attached to the Lensstar, which you can see in the bottom right. The axis and astigmatism measurement of the Lensstar is extended with true 11-ring Placido topography. This additional data improves the efficacy and safety of toric IOL surgery, eliminating the risk of irregularities and allowing the user to double check the axis location. Here I show a case of regular astigmatism where we show the image taken, so with the 11 Placido rings, we show the axial curvature, we show the tangential curvature, and the axial elevation. And here is another case with an irregular astigmatism, just to show to you as an example. This is the information the T-cone can provide to you, that you really have an insight before doing a toric, or before thinking about the toric IOL, that you really have an idea what is going on in the periphery of the cornea. With this said, I would hand over to Thomas to explain for the dedicated features of the Eyestar.
So thank you very much for this very comprehensive overview on the capabilities of the Lensstar for toric IOLs. And as mentioned by Michael already, this is a really comprehensive unit we have. And with the Eyestar, we are actually increasing the palette of tools which are available to the eye care specialist again. And therefore, I would like to show you not only in a presentation what we can do there, but also live on the unit what we can offer for the specific application of toric IOLs. So first of all, just a quick overview. I guess many of you have already joined us in previous sessions where we did talk about torics, where we did talk about the measurement features of the units and so forth. So what is the Eyestar? The Eyestar is not only just another biometry. The Eyestar is a fully blown swept source-based OCT eye analyzer. It provides full swept source OCT biometry of the entire eye from the cornea to the retina. It also provides reflective dual zone keratometry. And Michael already pointed out nicely that this is a unique feature of both units, the Eyestar as well as the Lensstar. And having these 32 marker points for measuring the corneal front power keratometry really provides very stable and very accurate measurement of the axis, the astigmatism, and the orientation for toric IOL. Now, in addition to the anterior keratometry, the Eyestar also provides posterior keratometry. So we can now also see if a patient does not follow the standard features like vertical steep, horizontal flat, posterior cornea, but something different. Let's say, for example, something oblique or something completely against the rule. So this is an additional feature that allows you to improve your refractive outcomes. The posterior cornea is used also in the IOL calculations with the Eyestar. So automatically, if you're using Eyestar measurements, then the posterior cornea is actually taken into account and used for the measurements. Then in addition, we have all the benefits of swept source OCT-based topography. The Eyestar features a full type A topography unit, and this provides topography of the anterior cornea, topography of the posterior cornea. It provides pachymetry. Then we get simulated keratometry from there. We get zone-based keratometry. We get Zernicke analysis of the entire cornea, and we can do vision simulation. And all these features I would like to show you now in a little live session, because I guess it's always best to really see it on the unit itself. What you see right now in the middle is the display of an Eyestar unit. I'm online connected to an Eyestar unit here. And we have here a patient selected. I quickly open the patient and the patient is loaded. So we have here the overview page of the Eyestar. It looks similar to the Lensstar, but a little bit more information is there. So we have the top left, top right, the anterior corner curvature. We have the uplight image in the center. We have the sections through the plane of the largest lens tilt in the middle. For the anterior chamber, we have the corneal, the retinal peaks in the bottom, and left and right, we have keratometry as well as axial length. So here in this case, we can see that this patient, specifically on the left eye, shows quite a nice astigmatism. It's a regular astigmatism, so vertical steep, horizontally flat. It looks quite quite symmetrical. Here, what we see is a little bit of asymmetry from the nasal to the temporal side. So if I go in here, I can now see additional information. One additional information which helps here a lot is zone-based keratometry, which is a nice tool if you are screening for toric IOLs. So if you have this information and the zone-based keratometry, like in this case, aligns nicely, you don't have any outliers of any of the axes displayed here from what the keratometry is, then you can say, well, that might be a good candidate, and we can go for a toric. You have the 3 millimeter zone, which can also be regarded as night vision, 5 millimeter, as day vision, sorry, a 5 millimeter zone, which can refer to night vision, and then the 7 millimeter, which is the peripheral zone with additional value for the assessment of asymmetries of the cornea. If I now go to the Wernicke analysis and the vision simulation, I can now show the patient immediately what the implantation of a toric IOL could bring. So here I basically just turn off the lower order aberrations. That's what I can correct with an IOL, and specifically with a toric in this case. And you can also see that Wernicke polynomial for the astigmatism is taken out of the equation, and that's the outcome. We have now a 6 millimeter pupil here, so that would be night vision. And we see that the toric implant really increased the optical performance of the patient. If we're using a toric implant with negative asphericity, let's say we take an Alcon implant, we can also compensate for the asphericity, and this again improves the patient vision a little bit. So these are additional features which are part of the Eyestar as compared to the Lensstar, which may improve your outcomes on individual patients dramatically. And it also provides you with more information to reduce the number of outliers. And let's see another example where we can have a quick look. What is the advantage to have the posterior cornea at hand? So if we go here and we look at this patient here, that's an against the rule astigmatism. So here we load the patient again, takes a few seconds. We see on the right eye, this is a nice example of an against the rule astigmatism, vertically steep, horizontally flat. If we click here on the topography, we can see cornea front against the rule, cornea back with the rule. And that's what you would expect, because most corneas of patients are following the posterior curvature with a vertically steep, horizontally flat pattern. And that's what's also in the monograms used in the respective formula if you don't have posterior corneal measurement. So here, the result of a Lensstar assessment and an Eyestar assessment using, for example, the Barrett's formula will be pretty much the same, because the posterior cornea of this patient pretty much follows the exact pattern of the monogram. Just a second. And if we now go to another patient with against the rule astigmatism here, here we have another one. And if we load this patient, then we see that here the result would be different between the Lensstar and the Eyestar. Again, on the right-hand side, it's an against the rule astigmatism. We see some asymmetry here, so it is on the temporal side a little bit stronger than on the nasal side, but still it is against the rule astigmatism. We also see that the zone-based keratometry supports the normal keratometry. And now if we look here at the posterior cornea, we see that there's basically almost no astigmatism at all. So if we again would use the standard monograms, which is basically half a diopter against the rule astigmatism, which would here with the against rule astigmatism corrected, then we will get a wrong result, not by a lot, but it could be the little tweak on the balance to have a perfect outcome or an outcome which is just close to perfect and might lose one line in the visual acuity in the end. So with the Eyestar, you have all the information at hand to provide best possible outcomes with any kind of implants, you have the laser-based biometry, you have swept source OCT-based topography of the cornea front, cornea back, and you have the well-proven and well-established 32 points dual zone keratometry at hand as one. So really, with the Eyestar and its fully automated measurement process that allows you to take a measurement of both eyes in just below 40 seconds, it's an easy to delegate task, specifically useful also in busy practices. So thank you very much. Let's see what questions might have arisen with this additional information. Okay. So one question I got for the Eyestar is, do you use the posterior cornea information? I said before, yes, we do use it for the Barrett formula already. So with the Barrett formula, and if you use iSuite IOL, and then it's automatically taken into account. So the formula takes the posterior measurement into account, adds this as an additional measurement parameter in the same screen as shown by Michael from the Lensstar. So the display, if you're already used to iSuite, will be absolutely the same. So you don't have to change your habits. You can basically continue, and the posterior corneal information is additionally added to the equation to provide with more certainty here. Then let's see if we have more questions. The question is a TK value available in the Eyestar? So TK, that's basically a rand of size. So size actually called their total keratometry value TK. And for the moment, we don't display a total keratometry value. Now you might ask, well, if you do it in the equation, why don't you show it? Well, that's a good question. The reason is pretty simple. If you provide a total keratometry value on display, you don't necessarily can just simply take this and use this in any IOL calculation formula. And we could have easily done this from the start, and we refuse to do this. What we are right now doing is we are collecting data from numerous cases of toric implants where we do have the Eyestar measurements of the patient, where we also have the outcome. And we are right now, as we speak here, deriving net corneal power, we call this here, because TK, as said, is a trademark, to then have the refractive power of the cornea available as a keratometry value, having the front and the back measurement at hand for the user as well. For the moment, we just do it internally in the formulas because the Barrett formula itself does not use the TK value from size or from the IOL Master 700. It uses its own calculation to combine anterior and posterior corneal curvature values. There's a question if we can calculate post-examiner patients with iSuite IOL. Basically, we can. I guess that's also something you could address, Michael.
Is it post-examiner surgery?
Examiner. That's post-LASIK, basically, I guess.
Oh, yeah. Yeah, we have the option to address this with our set of IOL calculation formula available, of course. There is, just to mention, I mean, I did not go into details about our formula and IOL calculation in general, because there is a following webinar, which is called the Practical Approach to IOL Calculation on the 21st of May. So I did not want to cover this topic as well. This is something which is coming up. And of course, you're welcome to join this webinar. So Thomas, it seems we have been pretty clear.
I hope so. It's that we have been clear and not too specific, and nobody wants to raise any questions.
Yes.
So basically, yeah, as mentioned already by Michael, the webinars are all recorded, so you can have a look at them also later on. They are on our YouTube channel. They are also available on our webpage. We have more webinars to come. As mentioned by Michael, there's a webinar on IOL planning in general on the 20th. There's another webinar of first experience, clinical experience with the Eyestar, which is on Thursday. And yeah, we would be very grateful if you would join in again. And yeah, if we could see or hear each other again. And yeah, answer more of your questions if you have ones. And also go ahead, contact your local Haag-Streit representative. If you have more questions, they are always very helpful and they are very positive to answer any of your questions. Thank you very much.
Thank you very much, everyone.